Good evening, everybody. Again, another fantastic night for the case box by IAVA CardioGo. This is the ninth wave, and I think in the previous eighth wave, we have a fantastic, unique, highly educative cases. And today we are joined elegantly by the Harefield Hospital from UK, and we will have a bunch of interesting cases, and I think it also unique cases. And it will be presented by elegant professors and experts, and it will be also discussed by elegant experts. We have today Professor Ayman Abul Magd, Professor Yasser Sadiq, Professor Nireen Okasha, Professor Yasser Hussain, Professor Ahmed Farid, and Professor Sunel from Liverpool Chest and Heart Hospital, and Professor Mohammed Zena, Professor of Cardiac Surgery in Liverpool Chest and Heart Hospital. I hope that it will be a fantastic night as usual, with great discussions and great benefits from the cases which will be presented. I will now give the mic for Professor Ayman Abul Magd to introduce the first case. Please, Professor Ayman.
Thank you very much. First of all, it's wonderful to be here. I congratulate you on the continuing series of CardioGo. Extremely interesting and educational series. And I know it's a lot of work, so I have to commend you for all your hard work. And for choosing the topics. I think the topic is LV support needed after the REVIVE trial, which is going to be presented by the eminent Professor Vasilios Panoulis, who is a consultant cardiologist at the famous Royal Brompton and Harefield hospitals in London, and the honorary lecturer at the Imperial College as well. I think it's very important because what happens is when you have the big meetings and you have the major trials being presented, and unfortunately, some people are not there to attend, and some people read the introduction of the study and the conclusion, and sometimes there is some misunderstanding regarding what exactly happened in a study that is supposed to affect our practice. To summarize, the REVIVE trial looked at people with impaired ventricular function, ejection fraction 35%, and they looked at medical treatment versus PCI, and their conclusion was there is no benefit for PCI. The very important point is those people did not have angina pectoris. They were just incidental findings. So I don't want to take too much of Dr. Vasilios' time. Please go ahead and enlighten us with your presentation, as always.
Thank you very much, Professor Mag. It's a great honor to be here with all of you tonight again. And indeed, this is a very interesting topic, and I'm glad that you just handed over to me. So just to introduce quickly myself, I work in this place called Harefield. Is the mecca of Professor Magdi Yaqub, as you all know, and he still now has a massive catchment area for primary PCI, and also now we're expanding our catchment for cardiogenic shock and out-of-hospital arrest. So as you can see, we're an outlier in the number of shocked patients that come to us through our doors. And I'll start with one case, and I'll show you a couple of cases before I go to my conclusions as to whether the revived results basically have changed our practice. And this is a chap that I did 4 years ago now. So he's now 75, which is a good thing, obviously, that he's still alive. He had all these problems with an EVAR, right endarterectomy, diabetes, blood pressure, smoker, and this LV function that, as you can see, is quite poor. He came in with transient ST elevation. So he had some chest pain, lifted up his STs, then kind of started settling down and went for a coronary angiogram. And as you can see here, his right was occluded, and it was a chronic occlusion, which is backfilling from the left side. And you see this extremely nasty left main disease, extremely tortuous circumflex disease. So rightly, because his pain settled down and the ST segments resolved, he was taken off the cath lab table, and the heart team discussed and agreed that he should be for an inpatient bypass, given that he's quite young. However, obviously, while waiting for his surgical workup, he started getting some chest infections, more pulmonary edema, recurrent episodes of chest pain, and transient ST elevations, a trop that was hovering at 7,000, and that really put off the surgeons a lot. And they kind of came back to us and said, could you guys take this case over and try and do PCI in that left main? I mean, all of us would not jump and do stents there. I know people have done it in the past and probably were doing a not fantastic job. And now we do a lot of these cases, but we do use support when we do such cases that need decalcification and things like that. As you can see here, this chap had a bit of a problem with his iliofemoral that were measuring around 2 to 3 millimeters, and he had previous EVAR and previous stents in his abdominal aorta. So we kindly asked our surgeons to put a conduit, and through there we managed to put a 5-0 impella, and that provided us a lot of support while we were doing this case. And I was personally very humbled by this case because I think I encountered every single complication that you can find on the book. And as you can see here, extremely calcified distal left main, extremely tortuous and calcified circumflex. So to cut a long story short, you can see just by bearing and rotablating that distal left main, I was losing pulsatility completely. But because I had the Impella 5, there was absolute stability for the patient. There was no loss and no crashing hemodynamics. So every time I was rotablating, he was doing that. And then I managed to do a good job. I started from the distal LAD. I then had every single complication in the book. I lost a balloon, got entrapped on the choice PTX support wire in the circumflex, and this is how the wire came out. You can see there. A stent came off its shaft and got dislodged. While trying to arrange that, I had a localized perforation over there in the roof of the left main. Several attempts with guide liners, an absolute mess of a case. Trying to salvage then that perforation, I put a stent from left main into LAD. We had a TOE down. We didn't have a perforation. We then had to recross that circumflex, do further work in the LAD, and then eventually do a reverse mini culotte and try and do also imaging to try and get the best outcome for the patient. This procedure lasted about 2 hours, and I can tell you I was sweating from the inside, but everyone else in the room was extremely relaxed because they had the ventricular support and the patient hemodynamics didn't really shift much. So we got a very nice result, and I'm pleased to report that he had his Impella explanted 5 days later, and he was discharged home a couple of weeks later. And I actually now have heard of him 4 years down the line, and he's doing really well. In fact, I did a control angiogram 2 years later, and it was just still fantastic, the result. And I think the reason I want to present this case, even though it was in the beginning of our experience, is the durability of the results that you can get if you do a good job. And here you can see the improvement in his ventricular function, 3 and 6 month follow-up. And I think that's kind of not to be debated. I want to highlight that this chap presented in the context of a non-STEMI via the primary route. Another non-STEMI case in a 78-year-old, again, that came from another hospital to us with a troponin of 1,500, MRI of 17%, preserved viability, these comorbidities, the potential of amyloidosis with cardiac involvement, but not absolutely certain. I'll show you the coronary anatomy. You can see here a very heavily calcified RCA, and indeed a heavily calcified distal left main. An LV that, you quoted whatever you like, is just not good on MRI, on echo, on every single modality. And then here is the angiogram I showed before. We decided to go straight with Impella because we thought we're going to be rotablating a left main of a chap with an ejection fraction of 15 to 20%. And we don't want to encounter any problems. You can see here how tight it is. This is not a lesion that you will be able to do with shockwave. It's just way too tight. And indeed, the microcatheter just about managed to go there so I can pass my rotafloppy wire down. So I did my runs with 1.5 there. Again, loss of pulsatility, the classic situation, but stable because of the presence of the Impella. And we managed to kind of implant our stents quite nicely. We managed to optimize the left main with POT. And I don't want to tire you with kind of interventional techniques, but, POT, kissing, re-POT again, IVUS, etc., and a very good final result, as you can see here. So this is kind of a result that I don't think I would have been able to achieve if I was just doing this case without support. And here again, and this is his ventricle 3 days post-PCI. You can see it kind of picking up a little bit, and I'll put them next to each other. That's before, and that's just only 3 days post-PCI. You can see that the ventricular function is starting to kind of pick up a bit more. Another quick case, and I'll close with this one, an 88 that had a 30% ejection fraction on a heavily calcified valve. Again, you can see here LV not very good. Combination of awful coronary anatomy with tight calcific left main, CTO of the right, and indeed a significant aortic stenosis. We went for balloon valvuloplasty, impella insertion after the balloon, shockwave in the IVL, and we delivered all 80 pulses of the shockwave without him having any hemodynamic instability. You can imagine without support, inflating a balloon in that left main wouldn't have gone down really well. And final result of the coronaries, we removed the impella through the 14th French peel away, and we kept that access and implanted the Edwards E-sheath, and through that we went with an Edwards valve. And we performed this procedure in a couple of hours under local anesthetic. So there was no intubation, no other sedation. He went home after 2 days, and his LV started recovering. These are 3 cases that obviously we know that this publication, Revive publication, came to light, but I think there's a couple of points that we need to be aware of. Number 1, who were the patients that were eligible? As you mentioned, there were patients with ejection fraction 35 or less, with extensive coronary disease defined as the British Jeopardy score more or equal than 6, and a demonstrable viability in at least 4 myocardial segments. That means there was no ischemia demonstrated in those patients. Absolutely no functional test done. We're talking about viability and a coronary Jeopardy score of more than or equal than 6. But more importantly, which patients were excluded? Patients with ACS and acute myocardial infarction were excluded in the 4 weeks before randomization. Patients with acute decompensated heart failure and sustained VTs and other ventricular arrhythms were excluded. No wonder why it took them 7 years, 40 centers to recruit 700 patients, because these patients don't really exist very much in our practice. There's not that many. The trial was very well conducted, and the researchers should be commended. But indeed, these are patients that we don't really see in our day-to-day practice. And as you very well mentioned, 66% of those patients did not have angina, which is a very odd thing to do. And this is how you classify this Jeopardy score. You can see a left main that is more than 50% gets a score of 8. A proximal LAD, if it's more than 70%, gets a score of 6. But we all now know that LAD of 70% doesn't necessarily mean that it provides an ischemic territory. It doesn't mean that this area has reversible ischemia. And unless you prove that, I'm not really sure what's the indication for revascularization. In the ischemia trial, they did a sub-analysis in patients that had less than 35% LV and ischemia, and they did prove a significant improvement in the LV function. However, on this Revive study, they showed no difference. So in conclusion, and this is a case that I just want to show you that obviously I don't do only cases with impella, I do cases without impella as well, because, yes, it's a commodity, but we don't always do it. And look at what happens to this man's pressure, which started at systolic 140. Once you start fiddling around with the last remaining conduit, it just plummets. And yeah, most of these people will survive, and you give them some adrenaline and your nursing stuff starts floating around and rushing around, and you start feeling a bit uncomfortable. And then probably you don't do as good a job as you would have done. So in conclusion, I think probably LV support is still needed. And the Revive, I have to highlight, even though an excellent study, hence in New England, it excluded ACS. In the majority of cases, they had no angina. There was no acute heart failure decompensated cases. No functional test was performed, and does represent, I think, in my practice at least, a very small proportion of the patients that we currently treat and see in our practice. Thank you very much for your attention.
Thank you very much. That was an excellent presentation. And I think you highlight several issues. I'm going to give my take, but I'd like to hear Professor Yasser Saudeh's take first.
Okay, thank you, Professor, for this excellent presentation. Actually, I'm totally agree with you. Still, we need LV support during high-risk PCI in some of cases. Actually, in Egypt, we don't have Impella till now, and we rely on intra-aortic balloons. And now, after the era of mobile ECMO, we depend or we rely on ECMO in some high-risk cases. And actually, I did like 5 or 6 cases, very tough cases with low ejection fraction with ECMO. So do you see there is any significant difference between the ECMO and intra-aortic balloon, because there is no preference for ECMO over intra-aortic balloon in clinical trials? But actually, we saw this in clinical practice. We got a lot of benefit from ECMO. So do we have any experience with ECMO for high-risk patients, or only you rely on your support device, Impella?
So it's mainly Impella, but we have done cases with ECMO, particularly if we want to fix at the same time the aortic valve. But the majority of the cases we do with Impella support, and if we need to escalate, we escalate with ECMO. We use very much ECMO in cardiogenic shock, particularly in the SCAI D and E cases, obviously if they're out of hospital cardiac arrests, because that's the only way to salvage someone with very high flows. Impella CP is just not enough for very deep shock, and I think that needs to be highlighted. But it's very good for protecting your high-risk PCI cases, and also it's a bit less invasive because ECMO needs at least 15 to 17 French arterial cannula and 25 vein, whereas Impella we're talking about a 14 French sheath with antegrade flow. So it's a bit more physiological than ECMO in this scenario.
Another thing, do you rely on LV and systolic pressure before inserting Impella, or you go directly with Impella?
Yes, we do always measure it, and most of the time we have started also putting a right heart cath at the same during the case, because it's also a nice way of deciding whether to remove it towards the end of the case. Because if we have LVDPs more than 20, despite the Impella, sometimes we decide, and some hemodynamic instability during the case, we tend to leave the Impella in.
Thank you so much. It's marvelous cases.
I think the hemodynamics, measuring the right side, the left, measuring hemodynamics, right atrial pressure and mean pulmonary artery pressure are very important to decide which modality you will use in those shock patients. I think you put up excellent argument for the use of Impella. The cases you showed are very compelling. As you know, the recent data, Impella has been sort of taking a beating lately, mainly because of the bleeding. But if you can avoid the bleeding, then it's definitely a very helpful modality in those high-risk patients. And I don't think anybody who would see those cases would argue for doing them without Impella. So I think these are the types of cases that really do benefit from Impella. And I think ultimately it will be shown. And like I said, even in the trials, the problem was basically the bleeding issues when you use when you have a lot of cases with Impella. And perhaps ultimately the French size will be smaller, but for now, this still remains an issue. Thank you very much. Those were wonderful cases. And you put a great argument that nobody can argue with, actually, for the use of Impella in those selected patients. Do you routinely use it, or are you selective in which ones?
Dr. Ayman, I think Dr. Vasil is because of
yes. Okay.
Is left.
Okay.
I'd like to give a comment here. It is not only the use of the LV support for life saving in such high risk cases is of utmost importance, but also I think, which is elegantly presented in his presentation, the follow-up. Look at the follow-up for 5 years. The outcome is great. The left ventricular function is improving, and I think this is also one of the important messages. It's not only life-saving, but also the long-term follow-up is great. I'm using LV support for such cases.
Absolutely. Generally, the perception has always been with those patients who are very high risk on the table, the most important issue is to go in and get the job done as quickly as possible.
Dr. Ayman,
let me just finish. The first case he showed was compelling in that he showed that the case had a lot of complications that without the support of the impeller, this patient would not have made it. Please. Yes, sir?
Yeah. Okay. So we want to highlight about the usage of ECMO now in Egypt, which is now it's affordable. I think the mobile ECMO, it's affordable, Dr. Nerine, because intra-aortic balloon now, it reached about 50,000 pounds, and ECMO now only 70,000 pounds. And I think in high-risk patient, it's like you doing CTO, for example.
We have a catastrophic case at the Academia transferred to us from the Mustashfa Al-Gawi. And we were about this yesterday. We were fighting to get him the ECMO. We have one, but the problem is that we don't have oxygenators. And the company said that there's no oxygenators anymore in Egypt right now. And we have to wait for 2 weeks to get the oxygenator. We called the one from the Asr Al-Aini, and he said that we have to pay 170,000 pounds.
No, I will give you.
And then every day the patient will have.
I will give you the contact for.
No.
I will give you as a contact for another company. I did 2 weeks ago a case in a private hospital, and it cost the patient 76,000 Egyptian pound. And I think we saved him because this patient had ejection fraction 30%, previous cabbage. He has only left main was circumflex, has CTO, right coronary. He has no lima, no LAD, and this patient crashed as when we inflated the balloon, and the ECMO did the job well, and this patient doing very well now. And I think we have to admit that, like with those patient, high-risk patient with low ejection fraction, with complex anatomy, I totally agree with Professor Ayman and Professor Said. We have to refer this patient for equipped centers and doing under LV support. I think this is the message we have.
The patient I'm telling you about, we did him on the undercover of the intra-aortic balloon, that he was transferred from his hospital on the intra-aortic balloon. And actually it helped us much. It really helped us much. He had a stent that was put, I think, in a wrong way from the left main to the non-dominant circ, which was
bifurcation case, not done as a bifurcation case. I knew the case.
No, it was not done as a bifurcation case, and a very small stent was put in the left main, and the patient crashed at the on table. Though he had an STEMI. So sometimes, even though the message is that you need to put your patient on the ECMO, but if you can't get it because of some technical problems, we have it as for free for our patients at the Academia at Ain Shams University, but we didn't have the oxygenator, and we failed to get an oxygenator. Don't lose hope. Sometimes the intra-aortic balloon Might have.
Yes,
Just
Dr.
use
Yasser?
everything you can use to support your patient. It is really needed.
Yes, Dr. Yasser Hussain?
Thank you. I think the main problem, not only the price of the Impella or the ease availability, but also the learning curve. And the major problem, I think, in my opinion, that most of the critical scenarios are not presented well in the clinical trials. Those who are 15%, 17%, with the question marks of the viability being started from the stage trial till this trial, I think it's a great dilemma. It's not just an instrument that is not at ease in every cath lab. What do you think, Dr. Ayman, about this?
Okay, here's what I think. First of all, we have different modalities for support. There's the balloon pump, there is the Impella, and there's the ECMO. The ECMO is basically a team. They do the whole thing for you, and you do the procedure. Balloon pump is very simple, but unfortunately, it was all we had for such a long time. And we always put it in because we had a balloon pump. But we never knew what it actually does in real life. And every single trial, unfortunately, has shown the balloon pump really doesn't do much. Now, obviously, there will be some, when I say it doesn't do much, I mean for the majority of cases. There will always be anecdotal cases where it will help. But when you look at a number of cases, most of the time it doesn't do anything.
That's what Revive did. That Revive did, that said that it was a negative trial.
No, Revive was not comparing.
Yes.
Impella or whatever. Impella was comparing medical therapy versus PCI in an ejection fraction 35 or less. That's all it did. It did not look at the modalities of support.
Yeah.
All the studies
but
looked
they
at modality. Sorry, I didn't hear you. Sorry, this will be up on a smash.
We are extrapolating the results.
I'm sorry.
I'm with you. I am with you. We are extrapolating the results. We are extrapolating.
Yes, for the balloon pump. Impella is new, and there is an extensive experience. Yes, in many of the trials, which were underpowered, really didn't show a significant benefit. But when you look at the centers that do a lot of cases of Impella, they learned. The learning experience is not in the technique. Impella, if you can cross the aortic valve, you can put an Impella. It's no big deal. The learning experience is in knowing when and for whom to put in the Impella. This is the real issue. This is the real issue with Impella. But it's very helpful for so many cases. The number of cases where it has been shown to be truly helpful is a big number, and the learning experience is in choosing when to put it in, and it really does help, like we saw in the cases in the presentation by Dr. Vasilios. ECMO is newer, and it's been helpful in some cases. You look at we have no data. I think nobody can argue with me. We have no data whatsoever. We have, again, building up of experience with ECMO to determine it works sometimes it doesn't work. But we're learning, like I said, with Impella, the true experience is in determining who needs it and when. The same thing exactly is coming with ECMO. We're just at an earlier phase of our knowledge. We are at a more advanced stage with the Impella, but ECMO is coming. It's a helpful component of the armamentarium, but we're still learning when and which cases where it will really be helpful. Unfortunately, frequently it is used for the very high risk shock patient, whatever. We don't know what to do. Let's do an Impella. Let's put in an ECMO, and hopefully things will get better. The learning experience is in determining who needs what. That's what I think.
Okay.
In the absence of data, we have no data whatsoever.
Okay, Dr. Vassilis is still with us. Dr. Vassilis, or you left already? Dr. Vassilis?
Yeah, I'm remote.
Yes.
Yep, I am.
We would like you to give us the solid criteria which you cannot go without Impella in such a cases.
Yeah, for me, it's simple. If you have a last remaining vessel that you need to do decalcification strategies, including rotablation, shockwave, etc., whether you have poor LV or not, I think you have to judge that. But I think particularly if you have an LV below 35%, I think you should not be doing these cases without support. Because you basically then increase the risk. And now, in fact, we're going to be doing this case as part of a randomized trial called BISIS CHIP3, and also as part of the randomized trial called PROTECT 4. Because, as you said before, the problem is that we have no solid randomized data to support this intervention. We all know we need some support from our personal experiences, but we also need to prove it in randomized trials so that then we can get it on the guidelines and we can get the desired funding for those devices.
Can I ask Professor Vassilis?
Yes.
Yes, okay, go on.
Yeah, Professor Vassilis, for severe aortic stenosis with low ejection fraction, what is your protocol in your center? You wait some days after ballooning with putting Impella, or what is the protocol for that?
No, so now if we need to treat coronaries at the same time, proximal coronary disease, particularly left main, and we have poor LV function and aortic stenosis, we do them in the same sitting. So we basically do single access, 14 French, BAV, balloon aortic valvuloplasty, then Impella, fix the coronaries, take Impella out, put the valve, seal the leg. So that kind of gives you the whole package with only one single 14 French access.
Sunel, you are with us? Sunel?
So Vassilis, so you prefer to do the coronaries before the TAVR?
Correct. We normally like to fix the corners before the TAVR. I mean, the reasons are that you put the Impella in before you put the new valve in, because obviously you can then damage the valve if you use the Impella post. And also you never can be guaranteed an easy access of the corners with any TAVI valve, no matter what people tell you. Core valve is high and gives you problems. Edwards sometimes also can be in front. The struts can be in front of the corners. So we tend to fix them before the valve.
So what my real question is, these are patients with severe aortic stenosis, and are they, you mean, my perception was these are incidentally discovered coronary lesions. Is that what you mean? Or are we talking about patients with unstable angina and so on?
So the reality is that the majority of those patients that have significant or critical coronary disease, say critical left main or proximal AD, more often than not, they have also angina symptoms and chest pain symptoms. And in fact, it's very difficult to dissect whether those symptoms come purely because of their stenosis or is a combination, but all of them are highly symptomatic patients. So, and obviously we pick them up as the workup for the TAVI happens, but obviously the main symptoms also are breathlessness and chest pain. And often they kind of mix with each other, and the etiology could be the aortic stenosis, the coronaries, or indeed both. So these are the ones that we tend to treat. We are very, we don't like to treat liberally patients with aortic stenosis, so we tend to not avoid stenting if possible, but if it's very critical, significant proximal disease, particularly left main, we tend to treat.
Perfect.
Sunel,
I totally agree.
Sunel, what's your input about the cases presented by Vassilis? Especially you are working in a different center in UK, which is the Liverpool Chest and Heart Hospital.
Yeah,
What is the scope of work in such cases?
Well, they're great cases. I mean, we actually don't have access to Impella, so we'd probably struggle with these cases. I mean, we might put a balloon pump in, although, as has been discussed, that's possibly just a placebo situation. I think if we got severe aortic stenosis, I'd be inclined to at least do a balloon valvuloplasty, then do the PCI, and then put the TAVI in as the sort of approach. But we don't have Impella, so it is much more difficult. For some of
you're still using the intra-aortic balloon there for such cases. There is any experience about ECMO also, or only intra-aortic balloon?
Yeah, we don't have access to ECMO either for these kind of cases.
Another experience from Blackpool, Amr Gamal. He is one of the also expert interventionists now. He is one of our colleagues in Zagazig University, and he is now working at Blackpool. What about the scope of working there in such cases, Amr?
Hi, Prof. Said. Hi, everybody. Hi, Vaz. Nice talk. So in Blackpool, we do have Impella, but we do have it on an uncommissioned basis. So this means that it's mainly available for us via donation. So we use intra-aortic balloon and Impella. We revert Impella for cases who are like single remaining vessel, high risk PCI, patient with single remaining vessel, whether Lima or high risk rotablation for a patient with critical anatomy. And for us to use Lima for these patients, it has to go through a number of discussions with the surgeons to make sure that Impella use is justified. So we don't use Impella as an ad hoc basis. So for example, if you got a primary with cardiogenic shock, we'll still use intra-aortic balloon because this is the normal pathway we use. But for patients who have been in the hospital a bit more stabilized in ITU, and they've got single remaining vessel, surgical turn down, severe LV dysfunction, we use Impella for these patients. Regarding skill-wise for Impella, I believe Vaz and Sonal Ozban will agree. I believe for Impella, it's mainly about skill of using large pool vascular access and the skill of crossing aortic valve. So as Prof. Ayman has mentioned, I don't think the technicality around Impella is difficult, but it's mainly about funding and patient indication.
Great. Because of the sake of time and because of the great cases, we enjoy it really. And I believe that it will be a non-stoppable discussion about such an important topic. But we have to jump to another interesting case. I think Professor Ayman also will introduce him. He's one of our eminent imager in Egypt and also one of the international figures. We would like to introduce him by Professor Ayman.
I thank you. I'm very happy. I'm always thrilled to introduce Dr. Hani Mahmoud Sayed. I'm thrilled and I'm happy and I'm proud to introduce Dr. Hani Sayed. He's really worked hard and he pushed and he learned and he improved and he has really made himself through his hard work, his effort, his intelligence, and his talents. I'm really happy to introduce him, and I'm as always, I'm looking forward to listening to his presentation.
Thank you so much, Professor Ayman, for such a very nice introduction, and thanks a lot, Professor Said Farag, for your amazing ideas and selections and these very interesting cases. And I've really enjoyed, although I'm an imaging guy, as it has been introduced, but I enjoyed the discussion about ECMO and Impella and so on. So for the sake of time, I'll just go straight. So the title is a bit weird, as you may have seen. It's narrowing everywhere. And obviously I'm an imaging guy, so it's about imaging. So this is a case that I have faced in Birmingham when I was working in the UK. She's a 28 years old lady. She is of Asian origin. She had shortness of breath, dyspnea class 3. She was known from before to have rheumatic heart disease, and she had mitral and aortic established valvular disease. And because of she was a bit obese, so the transthoracic views were not like conclusive. That's why she was referred to my TUE clinic. At that day, the question was not about the mitral valve affection severity. Actually, it was about the aortic stenosis severity. And if it is not severe, let's check the mitral valve for balloon valvuloplasty feasibility. So if the aortic valve was not severely affected, so the question in the TE whether to check the appendage, check if the appendage is clear, and assess the mitral valve anatomy for feasibility for balloon mitral valvuloplasty. That was the scenario when she came to the TE clinic that day. So the first image is the 4-chamber view, as you all know, a huge left atrium as it was expected, and mitral valve has the classic thickening of the tips with dooming of the leaflets. So no doubt about the affection of the mitral valve in this case. And the second look was about the appendage, which was clear. So that was reassuring in terms of left atrial appendage clarity. And then the long axis view started to show some weird stuff. That's a zoomed view of the aorta, the long axis view that shows A2 and B2 scallops of the mitral valve. And again, that confirmed the stenosis of the mitral valve, thickening and dooming of the leaflets. But let's have a look on the aortic valve, which was labeled as severely stenosed. The motion of the leaflets in that patient was actually normal. So the leaflets were not so affected. The valve was very happy valve. It's opening all the way to the sinusotubular junction. But the problem, as you can see, sinuses are okay, sinusotubular junction is okay, but there is a relative dilatation of the ascending aorta as compared to the LVOT and the annulus. And then leave that and look a little bit under the valve, and you see that the LVOT is a bit strange, like narrowed, and at the start of the LVOT, there is something like a ridge here, just below the mitral valve. So it's a kind of tubular stenosis of the LVOT, and the aortic annulus is small, LVOT is small, the valve itself was actually working nice. Color is very important. As you know from the physics, color is based on the physics of the pulsed Doppler. So the continuous wave Doppler will give you the highest velocity all over the cursor line, but pulsed wave Doppler will give you location specificity. So the pulsed Doppler as well as color, because color is based on the pulsed Doppler physics, it gives you the aliasing at the area of the problem. So that's why here we can see the aliasing starts at this ridge at the beginning of the LVOT, not at the valve itself. So the main problem was here actually, not at the valve itself. There is sub-aortic stenosis, and the stenosis here was not like sub-aortic membrane, the regular one that we usually see. No, it's like a tubular or tunnel-shaped LVOT starting from the very beginning of the LVOT. That's a long axis sweep, so I keep the probe in the rotation angle at 130, the same, but I just turn the probe from to the right to the left to get a sweep of the LVOT and the aorta from side to side in order to see the motion of the cuspis all the way from all directions. Again, another view of the commercial review of the mitral valve, again confirmed the severe affection of the valve with the clear left atrial appendage. And as a trick, we will come to this view again, okay, to make it interesting. That's more oblique view, just to assess the mitral valve. The gradient was not actually lying at all because the mean gradient was 17, so that valve was really stenotic, regardless the mechanism of the stenosis, but that valve was really stenotic. Now the 3D, as usual, you know, I'm biased a little bit with 3D. Surgical view of the mitral valve. I'm looking now from the left atrium, aortic valve at 12 o'clock position. This is the interatrial septum, tricuspid valve is on the right-hand side. And this is the left atrial appendage. You can see here from the valve opening and closing that there was something happening down, but there is at the level of the annulus, there is like a ridge or a shelf-like something here at the level of the annulus. Let's fix that in 2 frames in order to see it clearly. In diastole, the valve is opening, but there is this ridge-like thing at the level of the annulus. And when the valve is closing in systole, this ridge is becoming very clear. So it's like supra-valvular membrane or ring above the mitral valve, apart from the mitral valve itself. Going back to the view of the commercial view, you will see that if I stop this and I moved frame by frame, okay, you can see that there is something here different from the leaflet itself. This is the leaflet tip, but there is something, this ridge is above the valve and different from the valve. So this ridge is down to here, the leaflet is coming from here, and the tip is down here. So there is something at the level of the annulus, supravalvular mitral ring. Now go to the aortic valve. Try leaflet. Left main is very clear. We don't need cath in this patient. Left main is very clear here. And there is very minimal commissural fusion. Color is okay. We know the aliasing started from the LVOT itself, not from the aortic valve. X-plane is also very helpful here. I'm dropping my cursor line, cutting the non-coronary cusp and the right coronary cusp. That's why I'm sure here I'm saying the non and the right coronary cusp, and both of them are opening very well. So the valve itself is not stenotic. Trivial aortic regurgitation. By the 3D, again confirmed, there is very minimal commissural fusion at the beginning. Otherwise, the valve opening itself is very well. Another focus view to show you the tunnel LVOT narrowing. With measurements now, the LVOT was only 1.4. She is an adult, 28, and she was obese. So the annulus itself, or the LVOT, was only 1.4. The sinuses that looks normal, actually they were not normal. The sinuses is 1.8 and sanutubular junction is 1.4. And the ascending aorta that seems dilated was not actually dilated. It was actually only 2.7, but it was relatively seen as dilated compared to the narrowed LVOT and the annulus. So relative dilatation, but not absolute dilatation. And as just a reminder again, the aliasing starts only from here. This is an X-plane at the level of the LVOT. You can see the narrowed LVOT. And this is 3D TOE for the aortic valve from the ascending aorta. I'm looking now from the ascending aorta. That's why I can see like dilatation, and then the aortic valve is down. Now I will look from the LVOT. I'm looking now from the LV. Mitral valve is above the base of the leaflet, and this is the LVOT itself. You can see this ridge like a curtain down here, obstructing and narrowing the LVOT. Pulmonic valve was okay. Tricuspid valve was okay. And this is the biatrial view. Again, interatrial septum, tricuspid valve, and this is the mitral valve with the supravalvular mitral ring. So the data that we have so far are, we have supravalvular mitral ring or membrane, small LVOT with subvalvular aortic stenosis, severe MS with a mean gradient of 17 millimeters of mercury. So the question about the suitability of balloon mitral valvuloplasty is not valid in this case, actually, because it is not rheumatic to start with. So do we need other views while doing the transesophageal echo? Yes. Let's go to the stomach in this case, because that raised an alarm to check the number of papillary muscles in this case, which was actually 1. So that's a parachute mitral valve, a single papillary muscle with an LVOT obstruction for sure. With 3D planimetry for the aortic valve to measure the area of the aortic valve was only actually 0.9. So although the valve was opening nicely, but because the annulus is small, even if the valve is opening, the area of the valve at the end was only 1. So severe aortic stenosis because of small LVOT and annulus. Annulus also was very small, as you can see from the numbers. This is like what we are doing in TAVI, and the LVOT was small. The mitral valve area, the mitral valve itself, not at the level of the membrane, down was only 1.5 centimeters square. So the valve itself was stenotic. So we have stenotic valve, mitral, stenotic mitral, supramitral ring. Aortic valve was small, LVOT was small, and everything was narrowed actually. So any missing data, when we see this constellation of findings, narrowing here, narrowing there, narrowing there, we have to think about one more thing. The MRI or the multimodality imaging can help us seeing the missing data actually in this patient, apart from confirming the diagnosis of the single papillary muscle. We have to check the aorta, because the missing piece of information in this case is the coarctation of the aorta. If you have this coarctation that will be named as, we will see later. So what we have so far, supravalvular mitral ring membrane, small LVOT with subvalvular aortic stenosis, severe MS, mean gradient 17, and parachute mitral valve. All of this will lead to the diagnosis of Schwann complex. So Schwann complex is a constellation of left-sided obstructive lesions. The full-blown Schwann complex is supravalvular mitral ring, which is there, parachute mitral valve, which is there, subaortic stenosis, and aortic coarctation. If you have all of the four, this is frank Schwann complex. But we have incomplete Schwann complex, which can be any three of those four, such as our case. It's an under-recognized entity, relatively low mortality, but morbidity is very high because of arrhythmias, heart failure, and need for interventions. So this patient went for surgery, but the learning points here are to not take the previous diagnosis for granted. Remember, this patient came with a diagnosis of rheumatic heart disease, and the question was only the feasibility for balloon mitral valvuloplasty. Color aliasing and frame-by-frame display helps to detect the level of stenosis and obstruction. The mid-gastric views are very helpful to assess the pulmonary muscles if the transthoracic echo was not conclusive, like in this case, because of poor window. If parachute mitral valve, you should think about the coarctation of the aorta, because sometimes you will have the full-blown picture of Schwann complex. And utilize other imaging modalities whenever indicated. And thank you so much.
Thank you very much. That's wonderful. And as you mentioned, this patient was going to go for a completely different procedure based on the initial diagnosis. And then you came and did this, and everything is completely different. Yes. So that's why we have experts and people who have more experience and are more capable of adding things together. Because even though you detected some of the abnormalities, you still weren't satisfied, and you looked for another abnormality, which you found. You found the parachute, and then you were looking for the coarctation. So I think this is a wonderful case, and it really shows the impact of experience and expertise. We're very lucky to have Professor Heba Atiyah and Professor Ahmed Farid and Professor Zeina as cardiac surgeons' viewpoint. So I'd like to hear their opinions, starting with ladies first. Professor Heba Atiyah.
Thank you, Dr. Ayman, for allowing me to speak. Dr. Hani, an extremely interesting case. As this is my specialty, when I saw the subaortic tunnel, I said it's a Schwann complex. So what actually you made the point is the appearance of the subaortic. This particular shape of subaortic obstruction is very, very characteristic for the Schwann's complex. We don't usually see it with any SAM, as we say, because it has the particular muscle part, and the surgical treatment is difficult. It's cono repair, and many of these patients, they present in the as adults, as the degree of obstruction does not start with severe obstruction, as we see with the usual subaortic membrane, and the impact of this obstruction on the aortic valve, the damage to the aortic valve, is rather later than the usual membranous subaortic obstruction. It is a very nice demonstrated case. The views you got are very illustrative, and what I have to stress on that people should not forget the transgastric view, because many people, they miss the transgastric view. I always tell my colleagues and my students while they're withdrawing the probe of the patient, he should look at the ascending aorta. He should try to get a look at the arch to see if there is any aortopathy. And what's very interesting too is we see these patients, there are a number of patients of these variants, different variants, particularly with the supramitral obstruction that are diagnosed as rheumatic or even other diagnoses that is missed with pulmonary hypertension in some patients. Thank you, Dr. Hani. It's a very interesting case, really. I enjoyed it. Thank you.
Before Dr. Ahmed Farid will give us his expert opinion, I just want to say a sentence. The very first peripheral interventional course had a saying which applies so much here. I found myself remembering it. Every single course they had a saying on the advertisement. It said, "You see only what you look for. You recognize only what you know." And I think this case, what you did, just made me remember the sentence because it exemplifies the model of that first course. I don't want to take more of your time. Professor Ahmed Farid, your take?
Thank you, Professor Ayman. And I would like to extend your words by a proverb that I use in my life. It's eyes don't see what minds don't see. If you are not searching for something, you will not see it, even if it's in front of your eyes. So you should know this. Thank you, Hani, for the excellent case. And as Professor Heba said, when you see such a tubular LVOT, you should think about Schoen's complex. This is very characteristic. So when you see a very narrow, a tunnel-like LVOT, you should look for Schoen's complex. My question for you is about the grade of mitral stenosis. From the four-chamber view, I see the leaflets opening, and I can maximally say that this have a mild stenosis. And this is actually what appeared by the mitral valve area. Why I'm asking this? Because the gradient here may be high for a lot of reasons, like the patient heart rate is above 90. So this what makes the gradient is high. So this would change your decision. Would you intervene in this mitral valve, or you only go for this tubular LVOT? Because if it is mild mitral stenosis, and if the ridge is not causing significant stenosis, you wouldn't touch this during surgery. What's your opinion about that, Hani?
Thank you so much, Ahmed. And thanks for the very nice comments about the case. Actually, here, the gradient was actually a combination, due to a combination of all the level of obstructions. But I think, in my opinion, the main cause of obstruction was the subvalvular apparatus. The subvalvular in this case was very thickened and diffused as well. So I think that because of the parachute mitral valve itself, so no point of intervening with a balloon in this patient. Although the valve itself was about 1.5, something like that. The valve,
1.47.
Yeah, exactly. And the supravalvular membrane definitely will be bigger than this. I mean, the area remaining from the
exactly.
But the funnel-shaped orifice of the mitral, the real funnel here, this is the parachute mitral valve, was the main reason for the gradient. So by any way, she's going to go for surgery because of this subvalvular apparatus. The challenge in this case, as Dr. Heba said, was the aorta, how they will deal with it, like a cone procedure, augmentation. That's very challenging, especially in adult patients.
Yes, totally agree. Thank you for the nice case, Hani. It's a marvelous case. Thank you.
And now we would like to hear the input, which is very important, from our surgeon. Professor Zena, please.
Prof. Ayman, thank you. My camera was on, but it's not working. Unfortunately, I don't have experience in this kind of case because I'm an adult cardiac surgeon. These cases are done by some kind of adult congenital. These are the pediatric surgeons. They come to operate on these cases on our department. So I don't have enough experience to comment on this.
Dr. Hani, do you think that any pattern or any kind of imaging modality will help us, or sometimes requested if we find such a complex, to add more information, to uncover some of the hidden points in such a complex? Or do you think the end of the way will be the echo?
Yeah, that's a very good question, because actually this is one of the main aims and messages of this case is we need to utilize other imaging modalities if we really need it. It is not a routine thing, but in such cases, if we are looking for something, in this case, when I saw the single papillary muscles, I thought about the coarctation and tried to rule out this by the TOE, but the views were not optimum. That's why I had to go for the MRI. So MRI request was in Birmingham was actually easier than the CT because of no radiation. They have a big concern about that. And since she was labeled as like adult congenital heart disease, so the MRI was included in the package. But I was chasing the question whether this is like the coarctation or not. But if the case is simple, like a routine rheumatic heart disease with mitral stenosis, I don't think we need to seek other modalities. But in complex cases, like in congenital heart disease, I think no one, especially like in us1 or any other place, having congenital heart disease and going for surgery without a CT. I think that's a routine now to check if other extracardiac abnormalities, vascular system abnormalities. So they are very helpful, and I think it is not wise to ignore the importance and the added value of these modalities. Otherwise, we'll not be living in this world.
Yeah, I was planning to ask you why you did MRI, not CT, because if you are looking for coarctation, and there is an important message here. Even if you by echocardiography, you didn't find coarctation, but you still suspected it, go for CT, because the echo is only looking at the thoracic part and the upper part of the descending thoracic aorta. So you may miss coarctation that's a little bit lower down. So it's very important, especially if you have a clinical suspicions or like if you are suspecting Jones complex, you should do a CT.
Definitely, yes.
Again and again, thank you, Hani, for this marvelous case, marvelous presentation. We are all proud of you, your achievement in the 3D TEE and every echo modalities. And I think now let me introduce and let me to welcome my co-partner in this wave, Dr. Hatem Sulaiman. He is also one of the flying birds, which we are always proud of him. Actually, we see him everywhere in the world, try to teaching the new modality, which is came up to the stage, which is BOCUS. And I'd like to welcome him very much, and his very cooperative contribution in such waves of CaseBox. And I'd like to leave the mic for him to give a brief, and then we will let Dr. Yasser or Dr. Ahmed Said to introduce the coming case. Okay.
Professor Said, thank you very much. It's again an immense honor for me to be with all this great panel of professors and friends, and always a pleasure to come back to the CardioGo waves. This is the time we see each other and exchange knowledge and learn, and I'm very delighted, and thank you again for inviting me to this joint session with Harefield Hospital. Whenever you are ready, I can start giving my presentation afterwards.
Okay. Dr. Yasser, can you introduce the coming case, please? Because I saw you on your camera on. I don't know who is available, but Dr. Yasser here is available. Dr. Yasser Sadiq? Unmute. Unmute. Unmute your mic, Yasser. Okay, we can shift to other Yasser, which is Yasser Hussain.
Okay. Thank you, Professor Said. I may introduce Professor Hatem Sulaiman for giving a very interesting topic about the flow assessment after cardiac surgery. Please, Dr. Hatem.
Thank you, Professor Yasser. I'm going to share my presentation. So apologies, that's not the one. So let me just share the other one. Yeah. Can you see my presentation?
We can see and we can hear.
Yes.
Very clear.
Okay, thank you very much, everyone. So in one of the previous talks I give at CardioGo, I talked about integrated point-of-care ultrasound in an example of a crashing patient. But here I am discussing a different dimension. How would you utilize integration of point-of-care ultrasound in the context of assessing fluids and hemodynamic assessment in patients after cardiac surgery, which I think is a very pertinent topic to us in cardiology, in intensive care, emergency medicine, and also for cardiac surgeons. And actually this talk, I made it initially to discuss the concept with our cardiac surgeons at Brompton and Harefield. And this is the second or probably the third time I give it after the first discussion. So the integration means that I would like to use this as part of an extension of bedside physical examination. And the outline of the talk will be briefly going through the concept of point-of-care ultrasound, the rationale. As usual, I will use a case to illustrate what I mean by using this as a parameter to guide our fluid assessment, the challenges, and I will finish by some take-home messages. So point-of-care ultrasound is a way of assessing patients' hemodynamics, and it's different from diagnostic echocardiography because it is performed in a short period to perform a targeted examination at the bedside, and it's usually performed by the bedside clinician to answer specific clinical questions at the bedside. And this is the famous split between point-of-care ultrasound as a basic tool and the full diagnostic echocardiogram, which is performed by expert echocardiographers in a time which can take up to 45 minutes to perform a comprehensive examination. But what we are witnessing in the last year is that there is an evolution of point-of-care ultrasound because of the development of technologies that led us to see handheld ultrasound devices with pulsed wave Doppler, continuous wave Doppler, and even tissue Doppler in a handheld devices, which are available at the moment, and also more number of non-cardiologists who are gaining and completing accreditation in advanced echocardiography. And that's, I think, is blurring the line between basic exam performed by inexperienced people and diagnostic examination performed by expert accredited sonographers and echocardiographers. And now we are having an evolution of point of years old gentleman who was referred to us from another center with signs of sepsis, reducing organ perfusions, rising lactate base deficit. He was also hypoxic and mildly raised troponin. And as you could see from the apical four-chamber view, which is performed at the point of care, that the left ventricular function seems significantly impaired. And in another word, the ejection fraction seems significantly impaired. And when confirming that by looking in other views, the parasternal long and short axes, again, it demonstrates significantly impaired contractility of the left ventricle. But because in critical care, we don't really rely on ejection fraction, and instead we prefer using the stroke volume assessment by assessing the left ventricular outflow tract VTI, because it is more reliable estimate of forward flow across the LVOT. This patient had a VTI of 8.3 centimeter, which indicates a profound state of cardiogenic shock with a cardiac index of 1.46. And also, the right ventricular outflow tract acceleration time was shortened, which indicates increase in the pulmonary vascular resistance. And when assessing the diastolic function in this patient, again, with a handheld device at the bedside, the patient had elevated pulmonary capillary wedge pressure, and according to the NAGE formula, the estimated wedge pressure was 19, which could explain the patient hypoxemia. And also, when adding another dimension to examination, which is lung ultrasound, you could see the appearance on your left-hand side of moderate pleural effusion and large right lobar consolidation. And on your right-hand side, you're seeing abundance of B lines bilaterally, which illustrates the presence of alveolar edema. See, the patient had several causes to explain his hypoxemia. So to try to address the profound shock state of this patient, the patient was crashing and burning, and you discussed in details the utilization of Impella and ECMO. This patient was crashing and burning, required peripheral V ECMO implanted, and Impella CP was put as an offloading strategy in this patient, and he was provisionally managed and diagnosed as sepsis-induced cardiomyopathy. And after a few days of antibiotic therapy, we saw an improvement in cardiac function, an improvement in the VTI, and also improvement in the pulmonary vascular resistance and restoration of the normal aeration in the lungs, which allowed us to decannulate the patient from ECMO and remove the Impella. So until a few years ago, we used to think that this is the end of the story for critically ill cardiac surgical patient, because this is the time we are happy, we send the patient to high dependency unit, he's extubated, breathing normally on room air, but they often become edematous. And I'm sure you've all seen that patients who are surviving critical illness going to the ward in profound edema because of the excessive cumulative fluid balance, because they received lots of fluids during their shock states, also with abnormal renal functions. And these patients often come back to us in ITU for considerations of hemofiltration and dialysis. And that's led us to start shifting the concept from thinking about preload responsiveness as a parameter to justify us augmenting preload to increase stroke volume, to think about another concept, which is the concept of fluid tolerance. And this will be the aim of the rest of the lecture. So when we think of the right atrial pressure, or the CVP, we often used to think of it as a surrogate for the right ventricular ability to handle the preload. But we did not think of it as the afterload or the downstream afterload of organs. And this can determine the flow across the capillary bed inside the organs. And looking at this basic physiological equation, you will think that increasing CVP in this equation and in this context will lead to reduction of perfusion of organs. And we know that congestion systemically is very bad because there are many data which illustrates the hazards of volume overload in cardiac patients, after cardiac surgery, and even in medical internal medicine patients. And it does not only affect congestion of the heart or lungs, but it's also intestinal gut inflammation and dysfunction, renal congestion, brain edema, and liver and splenic congestion. And interestingly, very lately, we started seeing data which tried to link between excessive cumulative fluid balance and the presence of delirium after cardiac surgery. And this is one of the big dilemmas that we all face when we deal with cardiac surgical patients, when they go into hyperactive delirium, which prolongs their hospital stay and can also potentially increase mortality. In this study, which was a retrospective control cohort study, they found that after 48 hours of cardiac surgery, excessive cumulative fluid balance was strongly linked to the presence of hyperactive delirium in these patients. And when we go back to physiology again, thinking of the Frank-Starling curve as our main parameter in managing fluid status, augmenting the preload, trying to obtain the stroke volume of the patient, we forgot to look at the blue curve, which is not less important than the Frank-Starling curve. The blue curve is the Guytonian venous return curve, and they actually often work together. When you try to improve the preload by giving fluid challenge or passively grazing, at certain point, while you are aiming to increase stroke volume, you will start to see reduction of the venous return in the patient. And this has significant negative consequences. And that's why the new validated score to try to look into systemic venous congestion with ultrasound, trying to look into the inferior vena cava, the hepatic vein, the portal vein, and renal vein. And this validated score, which is recently, about 2 years ago, validated and published by the team at Montreal University in Canada, looking at 145 patients after cardiac surgery. Half of the patients were spontaneously breathing. The other half were mechanically ventilated. So it's equally validated in ventilated and non-ventilated patients. And with this, they found strong association between excessive cumulative fluid balance and high VEXA score, as I will show you in the next few slides, and the presence of acute kidney injury in these patients. And to simplify the VEXA score, it starts with the inferior vena cava as the gateway of the assessment, because if the IVC is collapsed, you are very unlikely to have systemic venous congestion. But if it's dilated, you have to go forward and assess the hepatic vein, and then the portal vein, and then the renal vein. The hepatic vein assessment relies on looking at the pattern of the hepatic venous waveform, which should be anti-grade predominantly below the baseline. If you see reduction of the velocity of the S wave compared to the D wave, or reversal of the S wave above the baseline, that indicates significant systemic venous congestion. The normal portal vein is non-pulsatile monophasic. So when you see portal vein pulsatility with rising pulsatility, that's another indicator of systemic venous congestion. And the renal venous flow, which is below the baseline, is almost the same like the portal vein. Normal is non-pulsatile and abnormal is pulsatile. And back to our patient, this is exactly the information we got when we performed the VEXA score on him. He had a dilated IVC with systolic reversal of the hepatic vein in the absence of tricuspid regurgitation, and his portal vein was more than 100% pulsatile, as you can see here. And this all indicates VEXA score 3, which is the highest score of VEXAs, and it means that the patient is flooded with fluids. And after aggressive offloading over a few days, luckily the right heart allowed us to do the aggressive offloading. The patient started to have improvement of urea, creatinine, and his sodium levels, and he was discharged safely from the high dependency unit without needing to come to the intensive care unit. And this is an algorithm that we proposed last year to try to integrate advanced parameters of echocardiographic assessment, not only spectral Doppler, but also tissue Doppler. And we also introduced left atrial strain as one of the parameters to try to look into the filling pressures, although we understand that atrial strain is not widely available in many centers at the point of care. And finally, it's all about integrated approach and thinking of how you would address the patient's hemodynamics with not only echocardiography, but also with utilizing lung ultrasound, and also thinking of the new dimension of assessment, which is systemic venous congestion assessment. But we should not forget about the challenges, because they are numerous: technology, governance, quality control, accreditation, training, documentation, the cost, the medical legal aspects. But in my perspective, the biggest challenge here is the mindset and the culture change in every institution and healthcare system. And I'm positive about it, because I think this is a wave of progress, and I see a lot of interest and improvement in practicing ultrasound safely at the point of care. And my final take-home messages from this presentation is it's time, I think, for us to rethink our intravenous fluid strategy, because I think fluids are not entirely friends. Fluids can be potentially foes, and fluids should be recommended and prescribed exactly as we do with medications, prescribing the dose of fluids, prescribing the duration of fluids, and the stop time and date of fluids. One of our surgeons argued with me that I should not make people scared of fluids. This is not my aim. My aim is to make people use fluids safely with using point-of-care ultrasound, and I hope it's clear to you. I think that point-of-care ultrasound should be an extension of bedside physical examination. Whatever I discussed in this lecture is not diagnostic ultrasound. This is an assessment ultrasound at the bedside using cutting-edge advanced technologies. And of course, this requires good training and accreditations at different levels of accreditation, not only for medical practitioners, but also for nurses and the other members of the multidisciplinary team. We should always use this information within the clinical context, because patients who are critically unwell after cardiac surgery have unpredictable hemodynamics. So when I find any of this information not matching the whole picture, I can sometimes ignore it. And it's all about using this multimodal approach where cardiac, lung, and VEXAS approaches marry up together to provide better assessment. And this is obviously an evolving field, and we're hoping and looking for further research and validation in the near future. And thank you very much for your attention.
Thank you, Dr. Hatem, for this nice different area. You took us to a different area. What do you think about the role of multidisciplinary team? Whom would be the leader or the main contributor? Those who are in the ICU, the consultation of the cardiologist, the opinion of the cardiosurgeon. How would this go as a team as regard the fluid after CABG or after cardiac surgery?
I think it's a teamwork. Again, whoever has the concept should try to embrace it and spread the culture within the team. But it's, again, a teamwork. I cannot entirely implement this without the support of our surgeons. And that's why my aim was first to introduce this to our surgical team. And they really welcomed the concept because it's physiology. You're not discussing something difficult to understand, but we often forget to look into these concepts. And ultrasound now has the opportunity to shed light on these important concepts. So I think it's a teamwork. I would not call for forcing these concepts without trying to convince the team about it and explain it to them. And education here is very important within the surgical teams. Of course, cardiologists will be leading in this because I always say and believe cardiologists with their leading echocardiography experience are the best suited to embrace and spread the culture of point-of-care ultrasound within cardiology and the other intensive care and emergency fields. And it's not only about medical specialties, Dr. Yasser, because I can tell you in my hospital, we started training the physiotherapists on lung ultrasound, and now we have 8 physiotherapists fully accredited on lung ultrasound. We started training outreach nurses on point-of-care ultrasound, and it's a culture that's spreading within the not only the medical team, but also the multidisciplinary nursing and allied health professional team.
So credentials to be fulfilled. That's what you.
Yes, absolutely. That's very important.
Okay, Dr. Yasser, could I ask Dr. Hatem?
Yes, please.
Dr. Hatem, thank you so much for this excellent presentation. Really, I enjoyed it. I have some experience for post-operative care. So in post-operative care, usually what we do, CVV, then if the patient needs fluids, go fluids, and the patient improved. And if the patient had adequate fluid, we do some inotropic support, and the patient improved. So from point of view, what is exactly adding value for ultrasound for those patients in cardiothoracic department or critical care of post-operative? This is one. Second, from intervention of view, now we encourage heart team after the era of TAVI and the complex PCI, and now we have large bore access. So it's very important to utilize the sonar usage in abdominal and in vascular as well. It is difficult for one to assess and diagnose if there is bleeding in the area of the abdomen by ultrasound, or it easily learned, because 1 month ago they brought me one specialist and he stated that there is nothing in the abdomen. And after that, the patient is crashed, and the problem is there is a tear in the iliac artery, and I diagnosed this with the angio. So, what is the tips and tricks for this? It is difficult, or it can learn it by some tips and tricks. Thank you for this excellent presentation.
Absolutely. Thank you, Professor Yasser. Yes, I will answer the first question first. So the question about IVC, right atrial pressure and CVP, and why ultrasound could be adding value. We know very well that central venous pressure is not specific in informing us about fluid overload. And it's not the best to guide us to give fluids because there are many factors which can cause dilated and increased central venous pressure in the presence of hypovolemia. Central venous pressure itself as a number is not the best indicator of fluid status. And that's why coupling central venous pressure, which actually equates to the IVC diameter and collapsibility, with ultrasound, give us better information about the true status of volume congestion or not. And the example here, if you have a high IVC, for example, or high right atrial pressure with a CVP of 15, you might still have low VEXA score. If you don't have portal vein pulsatility, if you don't have hepatic vein systolic reversal, then your patient is intravascularly dry despite high IVC, and that will inform you to give fluids. But if my central venous pressure is high with high VEXA score, I will not give fluids, and instead of that, I will aim to give inotropes if the cardiac output is reduced by echo, or I can give diuretics if the cardiac output is maintained. So that's why central venous pressure itself is not the best parameter, and it has very poor specificity in informing these patients, because we all know that these patients' cardiac output is depending on high preload. And if you are going to go and offload these patients, it has to be very cautiously, and preferably if they are critically unwell, it has to happen under invasive cardiac output monitoring. So then thank you for right heart failure question, because it's a very important question that relates to VEXAs.
Let's go also for some applicable issues. What do you think as regard the POCUS? It's not a mandatory now, till now, but till it becomes a mandatory scenario for those post-operative, whom are in need to do it as a must now? If you go to the real world, what do you advise for?
Yeah, of course. You mean the post-operative patients?
Yes.
I can tell that I do it for every patient because it does not take time, and it's a protocol. Once you get trained on it, it can be performed in 5 to 10 minutes. And I think it's very useful because many patients I discovered that they have important, significant issues, although they did not seem to have that clinically. So in real life, I recommend, and this is what I do when I teach, and most of my fellows and my colleagues now do it on a day-to-day basis on most of the patients. And I'm talking especially about cardiac surgical patients, because this is the period of hemodynamic assessment and unpredictable changes in blood pressure and organ perfusion.
But as the cardiothoracic guidelines, what do you think? Is there a place now, high recommendation or something?
No, not yet. No, actually not. So that's actually ironic. So although the use of point-of-care ultrasound is becoming widespread, and it's adopted by many national societies here in the UK and around the world, it has not been part of if we talk about the sepsis guidelines, for example, the surviving sepsis guidelines, the international one, now point-of-care ultrasound is a fixed part of the assessment, talking about focused echocardiography. But it is still a work in progress. We expect this to become more widely available. What societies are waiting for is to have more trained people and accredited people so they can adopt it on a larger scale. And this is the state of our intensive care society in the UK. So until now, ultrasound is not a mandatory part of the training in the intensive care curriculum. And this is unfortunate. But the reason is they still hope for more people to be trained. So when they ask everyone to do it, then you will have more mentors around to train you in hospital.
Yes, and at the end of the day, it starts like that in every issue.
And also, I think if the guidelines will be there, came up to the stage, I think you are the one who will lead to write those guidelines in the future, Hatem. I'm sure of that.
Thank you.
And I hope to be in the near future. I hope to be in the near future.
I hope so.
I think now, because also for the sake of time, we will jump to one of the. Thank you again, Hatem, for the contribution, for the nice cases, for the.
Yes, you made it. You made it very easy for us, really. Yeah.
Thank you very much. Thank you so much. Thank you.
We will leave the mic now to Professor Ahmed Al-Sayed to introduce the coming case.
Thanks, Dr. Said, for the very interesting meeting. It's an opportunity to share very good science in a very intimate atmosphere with a lot of friends and colleagues. So thank you for the opportunity. Let me introduce Amr Gamal. Amr is one of the pioneers in intervention cardiology and structural heart disease intervention, as well in Blackpool Cardiac Center, and a former intervention cardiology in Zagazig University. Amr will be having, of course, an interesting presentation with some challenging TAVI cases, as I've seen from the title. And we're actually honored to have in the panel and discussants my friend Yasser Sadek, and from National Heart Institute, Professor Sunail Agrawal from Liverpool, and Mohammed Zaina from Liverpool, as well as a cardiac surgeon. So please, Amr, we are all ears.
Thanks, Dr. Ahmed, and thanks, Prof. Said, for inviting me for this meeting. Just before we start, I would like to ask you please to keep Prof. Mutasser Scully, my previous mentor in Zagazig University, in your prayers. He's a bit unwell nowadays, and I hope he get well very soon. So I believe I'm sharing now. Is it coming on the screen now, Prof. Ahmed?
Yes.
Sorry. So my title today is about meeting the challenges in TAVI. And this is a center where I work now with Blackpool Victoria Hospital. So clinical background, we have got 70-year-old gentleman with previous CBG and Lima to LAD and vein graft to the right. In the same setting, he had mitral valve replacement with single tilting disc. It was back in 2008. There was previous history, and sorry, I got like an alarm here now. There was previous history of peripheral vascular disease, and the previous stroke was bilateral endarterectomy. Patient was recently admitted to DGH with heart failure and pre-syncope. Sorry, it's not helping. Sorry, I've got a technical issue. Okay, not working now. So here we can see the transthoracic images. Patient has got mechanical mitral valve single leaflet disc, which is well functioning. There is evidence of severe outfield stroke dysfunction. Ejection fraction less than 25%. At the same time, we can see there's evidence of severe aortic stenosis. And you can see here, despite severe outfield stroke dysfunction, the gradient across the aortic valve is peak gradient is nearly 81 and mean gradient is 52. So clearly severe aortic stenosis in the presence of mechanical mitral valve and severe outfield stroke dysfunction. So we proceeded to an angiogram for the patient, which was done in the peripheral hospital. They went through a left radial artery approach. Looking at the natives, we can clearly see that there's tight left main stenosis feeding a big circ, which is not grafted. There's also evidence of RCA total occlusion and LAD proximal occlusion as well. And here, looking at the grafts, you can see there is patent Lima to LAD and patent vein graft to the right. So clearly, from the coronary artery perspective, we can clearly see that circ is not grafted, and there is tight stenosis just prior to the circ takeoff. And as part of the workup, we did a CT scan looking at the femoral and the aortic annulus. So here I'm focusing now on the femoral arteries, iliofemorals. We can see that there's a good area for puncture just above the iliofemorals. In the leftmost panel, we're using Stretch View on Tremency, which is software we use for CT analysis. So there's a good area for puncture just above the common femoral bifurcation. However, higher up, we can see just at the right common iliac artery, there is severe calcification. And you can see here in the middle panel, there is concentric ring of calcium. And in the rightmost panel, there is severe there's big calcium nodule protruding in the lumen. Here in the lumen, at these two areas were less than 4 millimeter. So now we are left with three options. Either we go for surgery, which is going to be reduced surgery with vein graft, circ, and new aortic valve replacement, which has got high risk of reduced surgery in general. Plus, there was ascending aortic calcification, which specifically will increase the risk, as discussed with our local surgeons. The second option will be for TAVI and high-risk PCI to lift the main into LCX, for which we have to use a rotablation, and there's risk of interaction of the TAVI valve with the mechanical mitral valve. As well, there's risk of difficult vascular access. We know these femorals, and we have to do something for the right common iliac artery in particular. The third option is medical management, which I believe is hard for a patient with 70-year-old, not frail, to be left with medical management alone.
Amr, if I may interrupt you, because I think the presentation is not moving, and we are still.
Sorry, I was moving the presentation. Something is going wrong now.
I think you have to go to the slideshow.
Slideshow, yeah.
Amr, please
down to the right.
Just raise your voice.
Down to the right.
I'm sorry.
Down to the right. Just next to the magnification. Down to the right.
Slideshow. Sorry.
Yes, exactly.
Are you following now? Okay, so hi, it's me again. Sorry, it seems we got a bit of a technical issue. So, Dr. Ramd, I'm not sure where was the last slide you saw from your end. So, quickly going back to this patient, 70-year-old gentleman, previous CABG, and he's got mechanical mitral valve. He's got severe aortic stenosis as well, and there is severe alveolar dysfunction. Can you see the angiogram from your end now?
We can.
Yes.
Yeah. So here, looking at the natives.
Raise your voice, please, Amr. I can hardly hear you. If you can just get closer to the mic or something. I'm really sorry.
Okay. So here, looking at the natives here, we can see there's a tight left main feeding into a large circ, which we know it's not grafted. Looking at the right panel here. So we have to play one at a time. It does not allow me to play. So right coronary artery is CTO, but we know that coronary artery is supplied by a patent graft. Moving now to the graft themselves, we can see there's a patent Lima to LAD, and there is a patent vein graft to right coronary artery. Might take a while to play. Shame. Okay. So we know that you've got now two patent grafts, one to the LAD and one to the right, and we know now that circ is not grafted. So with the CT scan as part of the workup, whether we go for surgery or TAVI route, and first we identified a sweet spot, as we call it, for puncture above the common bifurcation, above the common femoral bifurcation. However, further upstream, there was severe calcification in the right common iliac, and I hope you can see it from your end. In the middle panel, there is concentric, what you call it, napkin ring of calcium in the right common iliac. And a bit higher up, there was mainly like a calcified nodule. Can you see it, Dr. Yasser or Dr. Ahmed?
Yes, it's very clear.
It's very clear.
I'm sorry, just like to make sure that, I don't have a technical issue again. Thank you. So the lumina here was reduced to less than 4 millimeter, which means, which, as you know from experience of expert TAVI operator in the panel, it's not enough for delivery of TAVI sheath delivery. So here, we had three options. Clearly a surgical route, which is surgical AVR, plus, vein graft to circ, which wasn't grafted. We discussed with the surgeon, and he felt the risk would be high. It was, risk of reduced surgery plus the risk of ascending aortic calcification, which is going to make the risk much higher. The other option is percutaneous approach with TAVI, which need to be preceded by high-risk PCI from left main into the circ via rotablation. There's a risk of interaction with the TAVI valve, as we know, with mechanical mitral valve, which I'll come to it in my next slides. Risk as well of difficult vascular access, as we saw from CT femorals. The third option, which we're left with, would be medical management, which would be hard to justify this in a young, physically active 72-year-old chap. So a patient was discussed at our structural MDT, and we felt the best way forward to go for high-risk PCI followed by TAVI. Structural team discussion revolved around whether we use balloon expandable versus self-expandable valves, given the concern between the TAVI valve and the mechanical mitral valve. We felt on balance, if we aim for a 90-10, 90 aortic 10 ventricular deployment with a balloon expandable valve, we should aim for a depth around 1.6, 2.3 millimeter if we use S326 Edward. Of course, if we aim for a higher deployment, the other risk is risk of coronary obstruction. And here we feel the coronary obstruction risk is not an issue because coronary height, which I will discuss it later, was acceptable. So we felt if we go with balloon expandable rather than self-expandable, aiming for higher deployment, we should be okay. However, we acknowledge that self-expandable, of course, has got the advantage that we can recapture or snare the valve into the aorta if there's significant interaction with the mitral valve. So before we do that, we tried to send the patient for PCI, and here PCI was performed via right radial artery approach. And you can see with the left panel, we use rotablation, and then with plays, patient end up having PCI, left main into the circ, one stent, back to the left main ostium, looks really well. There's no problem with the stent. But again, here we use right radial artery, and during the angiography, we use left radial artery. So actually after PCI, we were left with no right or left radial access for the pigtail. And this means actually we have to use a bifemoral approach, which means increase the risk of vascular complications. And here, we used Tremencio for CT analysis. And here we used, we identified the level of virtual annular plane for the street cusp of the aorta, and a of 3 leaflets or 3 sinuses. And now we can see that, as we know, for the balloon expandable valve, we mainly depend on the area. So the area of the annulus was 597 square millimeter, while the area in the LVOT was 489 square millimeter. I believe we got expert TAVI operator who can advise that the annulus and the LVOT each fall in different valve categories. So we can see here from the valve specs for Edward that the annulus falls actually in the S329 category, while LVOT falls in 26 category. So this is something is very important when you get like a annulus and LVOT with borderline sizing. We have to decide which one is best for the patient, either to go for oversized 26, like add 1 mil extra, or undersized 29. An important factor as well for decision making is the length of the balloon and the size of the balloon as well. We know this, these are balloon expandable valves. The valve is mounted over a balloon. So if you use a 26 millimeter Sybian, the balloon length is 32 millimeter shoulder to shoulder. While if you use 29, the balloon length is 36 shoulder to shoulder. Plus the balloon width is be different, 26 for 26 Sybian and 29 for 29 Sybian. So an important factor as well, as we said, for decide the implant depth and how safe we can go, is decide about coronary height. So left coronary artery and right coronary height were both reasonable, above 10 millimeter, and we know a patient has got grafts, but our concern, if any, will be around about the ungrafted circ, a left main into the circ. But I can see left main height was 17 millimeters, acceptable. So here we used 3D reconstruction. We looked at the distance between the aortic annulus in this picture is represented by this thin red line and the mitral apparatus. You can clearly see the mitral apparatus showing up on CT. And here is like VR. We can see the aortic annulus around this plane, around this red line, and the mitral apparatus just very close to it. So we had to get some objective measurements. So we measured the level from the aortic annulus into the mitral apparatus and came back as 5.7 millimeter, which is actually acceptable, which I'll come to discuss about, what are the minimum reference diameters reference for distance from the aortic to the mitral annulus. Another important measurement is the angle, the aortomitral angle. And here we found the angle around 115, which again is acceptable. From literature, the risk is high if the angle is around 90 degrees. An important function of TRIMINITY software or any other CT software for TAVI CT analysis is that you can do what we call virtual valve assessment and see if you use 26 or 29 or different valve, how it could interact with the mitral apparatus. So here we use the virtual 26 valve. We can see the valve 26 millimeter diameter, and we aimed for 90-10, 90 into aortic and 10 into left ventricular outflow tract. And here, another angle for the valve, 90-10. We can see with the valve itself, the risk of interaction with the mitral should be minimal because there is enough space. When we say around 2 millimeters of the valve into the LVT, shouldn't be of an issue, especially if we know that the distance is nearly 5.7 millimeter annulus to mitral valve. And here we use this cross section. We made a circle of 26 millimeter at the level of the valve annulus. We can see 26 is really acceptable at the level of the annulus. It's catching all hinge points at the level of the annulus. Again, we use the same with 29 because very important to decide which one is best for the patient. So 29 is around 2 millimeter longer than 26 valve. And if we aim for 9 to 10, again, it's not much of an interaction of 29 valve itself with the mitral valve. Again, see, there's still a safe zone, like a couple millimeter between the valve and the mitral valve. And again, when we reproduced how the valve will look like at the aortic virtual plane of the aortic annulus, we can see that although 29 looked a bit acceptable on previous measurements, it seems slightly oversized at the level of the annulus. As I mentioned before, the one important factor in decision making is balloon dimensions. So with 26, we'll use 26 balloon, which we know 32 millimeter. So we can see there is minimal touching, or I would say some contact. We expect some contact of 26 balloon with the mitral valve. We can see it in different angles. But what's important here in decision making is how big is the LVOT at the level of the mitral annulus, whether there's enough room, space for the balloon to go without impinging or disrupting the mitral apparatus or causing LV perforation, like septal perforation, if there's no space for the balloon to go. So we did some objective measurements. So here we use this red cursor line represents a measurement which was done in the LVOT at the level of the mitral. And we draw a circle of 26 millimeter, which should be the size of the balloon. And we can see the balloon is acceptable, actually. It should be minimal interaction with the mitral because there is space for the balloon to go. And we did the same with 29 millimeter balloon is going to be longer. So it means we'll dive deeper into the LVOT. And if we do the measurements, we can see at the same level, 29 theoretically should interact more with the mitral apparatus. So we felt 29 is more risky to use. And we decided based on this to use 26 valve and add 1 mil extra just to help for final deployment. So to start the procedure, we made a plan upfront to severe calcification in the right common iliac. So we decided to use a shockwave upfront. So we got assessed by interventional radiologists and with shockwave from the aorta, shockwave balloon, 5 millimeter shockwave balloon, 60 millimeter length from the aorta into right common iliac. And this is the final picture after we did shockwave. Of course, we went via percutaneous approach into common femoral artery above the bifurcation. And we did upfront pre-dilatation of the right common iliac stenosis using a 5 millimeter shockwave balloon. So by doing this, I believe we modified the compliance of the vessel at this area, which permitted and allowed us to pass an Edward sheath in. And now we got, as I mentioned, because we lost left and right radial artery, we had to advance the pigtail from the left femoral approach, which from the start was diseased, but we felt it was 5 French pigtail, so it should be acceptable. However, you can see here on subsequent image on the right hand side. Sorry, it was freezing. So there was some interaction because of tortuosity in the aorta and femorals between the pigtail and the AL1 diagnostic. And you can see there is some contact between these two casters, which end up the pigtail moving up into the sinus. The pigtail should stay in the non-coronary sinus to help us for precise deployment and make sure that we don't deploy the valve too shallow or too deep. But unfortunately, because of tortuosity, calcification, the pigtail keeps moving up. And just, when we advance the valve itself, S326, the pigtail kept moving up all the way up, and we couldn't re-advance it down. And we can appreciate that the valve delivery system is bulky, so the problem is going to be a bit worse. So actually, we had to depend on the deflection of the O3/8 wire across against the aortic valve as our landmark for where to deploy the TAVI valve. Another marker, of course, is the calcification of the sinuses. But again, in this scenario, I have to say some centers start to use single axis for TAVI. But at this point in time, we haven't yet started. So for us to start our single TAVI axis in a patient with mechanical mitral valve, where we know precise deployment is very crucial, was really not without a risk. If Prof. Ahmad, Prof. Said, and Dr. Agarwal as well can notice the Sybian is off the balloon. So the balloon, the valve stent should be exactly in the middle of these two balloon markers. So we can see that actually the balloon is ahead of the valve into the LVOT, which is something we need to take into consideration when we do the final deployment. Of course, when we deploy the valve, we had to keep an eye on precise deployment, position, depth, and the mitral valve as well. And this is deployment. This is deployment shot. So we start with the position. We use this one as our landmark. We aimed for 90-10. So ideally, we should have started a bit higher, but because we can appreciate from the last image that the balloon is ahead of the valve, this means if we aim the lower end of the marker to be just at the level of the wire, it should be fine and help us to achieve 90-10 deployment. And of course, in all my TAVI cases, my main concern is always the valve. But here, my concern was not just the aortic valve, but also the mitral valve, because I was concerned about the mitral valve, can go down, can get acute dysfunction of the mitral valve during the procedure. And this is our final shot. Before we left the cath labs, it was trivial BVL. Mitral valve was well functioning. We had to use a pigtail from the right common femoral artery just to get an accurate estimation of the valve via orthography. And you can see the left coronary artery is patent. Patient had transthoracic echo, and we can see here the mitral valve is well functioning, the same as the aortic valve. So here we move to our learning points. So as we know, patients with previous surgical mitral valve were routinely excluded from all TAVI trials, namely partner trial. TAVI in these patients cohort is technically a challenge due to respective proximity of the aortic annulus and non-compliant rigid prosthetic mitral valve ring. These patients are at specific increased risk during TAVI from possible interaction between the mitral and the aortic prosthesis. Risk as well of mitral prosthesis close to the aortic annulus may cause inadequate expansion or embolization of the TAVI valve. Risk as well of mitral valve leaflets damage by the stiff guide wires. And finally, there's an increased risk of endocarditis on follow-up. In my next slides, I will talk about how to mitigate these individual risks. So we talk about risk of interference of TAVI with the mitral valve. Meticulous pre-procedural planning is very important in these patients, which includes measuring the aortomitral angle and distance. In a lot of literature research, including Spanish registry, they mention about there are some criteria for defining these patients who are at increased risk of valve dysfunction and interference during TAVI, especially if the aortomitral angle is 90 degrees, or if the aortic annulus to mitral prosthesis distance less than 7 millimeters, or if the valve was implanted anatomically if it's bileaflet, or anti-anatomically if it's single leaflet disc with a major orifice opening towards LVOT. Of course, it's intuitive to think that self-expandable valves have the advantage of being recapturable during adjustment should any problem happen with the mitral valve prosthesis, while balloon expandable valves have got the advantage of they are shorter stent frame. But of course, with balloon expandable valve like Sybian, it's one shot, so it's once it's deployed, you can't modify the valve, you can't snare it, you can't recapture it. More literature evidence support that although 7 mm is the optimum, but it's very hard real life to get 7 mm distance from aortic to mitral annulus. And they advise there is minimum acceptable distance from aortic to mitral. 3 mm for Sybian if you go transfemoral, 8 mm for Sybian if you go transapical, and 4 mm if you use a core valve. Of course, we have to use an X-ray angle that clearly show both mitral and aortic projection, both mitral and aortic valves, and the distance between the two valves, to be able to correctly deploy the valve without interaction between two valves. And ideally, most of us use iliocranial three-cusp view for deployment of Sybian valve. Of course, another important factor while you think about how the TAVI could interact with the mitral, you need to bear in mind that if you implant too high, you may end up having a problem with the coronaries. So coronary height here is very important as well. Usually we use like 10 mm as a cutoff point for risk of coronary obstruction from the aortic annulus to left coronary height. So in my case, there was no problem with coronary height. The other problem is risk of valve embolization. And as we know, mechanical valves have got rigid housing cage and protruding pivot guards, which can cause balloon displacement towards the aorta during inflation, which can result in valve malposition or sometimes valve embolization. It was found that Sorin valve had a narrow housing cage, while the On-X mechanical valve has got a high rigid housing cage with leaflet guard that extend into the LVOT. To prevent valve embolization, the operator should pay a lot of attention to delivery catheter and should apply some forward tension on delivery catheter in order to resist the opposing forces pushing the valve up into the aorta. Deployment should be done very, very slowly to check for and correct any movement during deployment. Last two slides here talk about risk of guide wire entrapment in the mitral apparatus. Of course, here's one of these scenarios where it's unacceptable to cut corners, and for example, you use AL1 and then jump straight away to a stiff wire. You need to make sure you use a big tail. Big tail is freely moving towards LVA because without interaction. You need to make sure the mitral valve, the stiff wire as well, towards LVA because without any catchment on the mitral. So in conclusion, TAVI could be safely performed in patients after mechanical mitral valve replacement. Thorough preoperative procedure planning with a multidisciplinary team is mandatory for optimal results. And finally, meticulous evaluation of aortomitral anatomy and TAVI implantation method by CT is very crucial. Thank you for your attention.
Thanks, Amr. It was a really great overview and very good planning and illustration. Congratulations, Amr. I think you will be having some discussions from the panel. I myself would like to start with when it comes to pre-procedure planning with a patient with already well-functioning valve in the mitral position, and you need to put a TAVI device in the aortic position. What we are really concerned is interaction with the new valve in the aortic position with the leaflet moving, leaflet motion, I mean. And of course, some valve platforms like the St. Jude, like the On-X, as you mentioned, even if you interacted with the ring, the leaflets are always away. The range of movement of the leaflets is always away from the newly implanted TAVI device. But I don't think, I think in your case, this was a bit different. What was the valve type? I think it was a single leaflet design. What was the valve size? It's single leaflet design. I myself would have implanted a self-expandable platform rather than a balloon expandable platform. because with a self-expandable Evolut-R, for example, you have minimal interaction with the mitral position, and it has the advantage of being retrievable and repositionable. And with the balloon expandable platforms, even they are shorter frames, and this is one advantage. But on the other hand, you have the balloon that will definitely interact with the mitral position. I know there are always more than one way to do a successful case, but I myself would have chosen another valve platform. The other point is you are lucky enough having that Shockwave peripheral balloons, and you've tackled the femoral axis in a very beautiful way. We don't have that peripheral Shockwave balloons yet in the Egyptian market. And in that case, I think I would myself have chosen the carotid axis as alternative axis for this particular case. I'm waiting for your feedback, and I think Yasser is having a few questions as well.
So thanks, Dr. Ahmed. So I agree, to be honest, self-expandable are a good alternative. But to be honest, in a way, it worked well, because for self-expandable, if in my slide, the big tail kept moving up. And with self-expandable, we need a stable position of the big tail. So in a way, I'm not saying it was intentional or so, but maybe, after discussion, we felt that to go with balloon expandable in this scenario. But I agree, actually, the majority of literature actually talks about self-expandable, as you mentioned, which offers the advantage of recapturable and repositionable. You can recapture and reposition the valve. So of course, it's a very valid option. And it depends as well on familiarity of the operator, which one you feel more comfortable using. Maybe we use as well more Sybian. In my center, we use 80% Sybian, 20%, we use actually Portico as a balloon expandable, the self-expandable, sorry.
Okay.
So we felt that, we'll be able to get better results with Sybian. And as I said, the fact that the big tail moved up, I think now I say I'm lucky that we went well with Sybian, actually. Regarding carotid intervention, this patient has got actual previous stroke and had previous carotid surgery. So for me to use a carotid as an alternative axis, I think if I can manage with a femoral, even with using like peripheral balloon angioplasty, the normal one, not just Shockwave, like an ordinary 5mm balloon or peripheral balloons. Here in the UK, we got interventional radiologists. So I believe in Egypt is vascular surgeon who. So what we do in my center, we go body up for them in this case is because interventional radiologists have got more experience in dealing with these scenarios. So even if I have to use Shockwave, I go them to body up with me. So because they have got more experience in using peripheral Shockwave, peripheral balloons. They have less experience with using Shockwave, but we have got more experience as coronary interventionists from using Shockwave in the coronary setting. So for us to put a Shockwave in the peripheral, it's not actually, it's exactly similar as the coronary. But the setting we work now, we got the interventional radiologist to body up with us.
Thank you, Amr. That's the case. I think now the era here in Egypt after TAVR with the incidence of rheumatic heart disease, I think we faced a lot of patients with previous mitral valve replacement, and now they had aortic stenosis and they asking about TAVR. And I'm totally with Ahmed for a lot of reasons. We prefer self-expandable valve. We can breathe smoothly when we deploy the valve. We recapture the valve again. And I think this is one of the advantages. And second advantage here for the Egypt, I think cost effectiveness. And for the Shockwaves, actually now we have Shockwaves for peripheral intervention with one of the peripheral companies here in Egypt. But actually it at a cost of $5,000. So it's we facing already the problem of cost for TAVR. So I did one case, like your case, a patient with previous CABG, and this is very important because you can't go with subclavian, for example. And actually, I'm totally agree with Ahmed that we have to think about transcarotid. But I don't know why in Egypt, this is for Ahmed, why surgeons don't recommend the transcarotid. I think a lot of surgeons, when we talking about them with this access, they deny this access for different causes, and all trials, all centers, they go with transcarotid than transaxillary, for example. It's more favorable, less stroke rate, and I think we have to have one in every heart team, like you, like me, and the surgeon, to be prepared for transcarotid, because we all of us, we want to make the cost less. This is very important. And Amr, I will ask you about the planning. You get a lot of thinking about to take 26, 29 for touching of the mitral valve, actually. I think it's a general rule that we have self-expandable and we have balloon expandable. And the pathology is the same. The pathology is calcification. So I think in balloon expandable, if I have a gray zone, I always undersize with 1 cc more, as you mentioned, 26 with 1 cc more to get the correct size, not 29 and get 1 in severe calcification or in calcific aortic valve. And I intended to oversize with self-expandable. I mean, if this patient, I know his sinuses dimensions, I think I will go for 34, for example. So what do you think about that? And after that, Ahmed will answer about the surgeons.
Of course, a very valid point. You're absolutely right. With balloon expandable, it's always the right thing to undersize, and with self-expandable to oversize. So it's absolutely right. Might be, it's more, I went into more detail of CT, what we did. I think the downside of 29, of course, it's not just interaction with the mitral, but if the balloon has to go somewhere and there is no space, as you know, for the balloon to go, talk about the Sybian balloon, there's a risk of, LV perforations, there is a risk of annular rupture because the balloon has to go somewhere. So it's not just about, of course, impingement of the mitral. But I agree, of course, as a rule of thumb is to undersize balloon expandable. I agree as well. If you're familiar, with self-expandable and you believe that you can get good results with self-expandable, of course, self-expandable has got an additional advantage of in this scenario. Regarding alternative access, can I ask you, why? My understanding, the majority of centers using alternative access, they use axillary or subclavian. So, what about axillary or subclavian as an alternative access rather than carotid?
In this case, I can't go because of Lima, but in general rule, in general rule, we now we have some experience for subclavian because it can done percutaneously, and the closure will be with 2 ProGlide. So I did like 1 or 2 cases, and but for transcarotid, I didn't have any experience with that.
Okay, yeah, I think I have a question for Sunair Agrawal as well. Whenever you don't have a proper femoral access, what are your protocol in this situation?
Yeah, I mean, I think in this case we would have used Shockwave. So that's I think since we've had access to Shockwave, actually our number of non-transfemoral access is reduced. And the other thing is we now have a very close relationship with our vascular surgeons. So if Shockwave's not suitable, sometimes we do it in conjunction with vascular. They might do a cut down or possibly a small conduit onto, a little bit further up for us to deploy the valve. So I think that now has become our preferred option. And we were a big transapical center. Now we probably only do about 5-6 cases a year, and everything else. So we do just over 300 TAVIs. I think in the last year, maybe 5-6 transapical, and everything else has been femoral, maybe with surgical help. So I think we are even transapical. We're now moving away from that, and we've got some plans for the sort of transaxillary access.
Okay. In our team, actually, we whenever the transfemoral access is no option, we go from the axillary access or the subclavian access. And if not feasible, as in cases where the patient is having already a functioning edema, we go from the carotid. And we have like 5 cases that have been performed successfully from the carotid axis. You have to perform first, CT to make sure that the carotids are well functioning. And then we go for an MRA to make sure that there is adequate collateral circulation at the level of circular villus, to make sure that there will not be some sort of brain ischemia during the procedure. Our surgical colleagues are more cooperative, Yasser, and I'll send you our surgeons to help you in your next carotid case.
Actually, Amr, these cases carried a lot of challenges, starting from the vascular access to the implantation for the Ure valve in such a situation with a metallic valve there. And I think here the issue is the meticulous planning. It is not a straightforward case. You have to do a meticulous planning for every step you will take, you will decide to go. This is a very important message here from your case. It is not a straightforward case, and you have to take your time and the multidisciplinary team discussion with the vascular surgeon, with the heart, with the cardiac surgeon before you took the final decision. And my question here is what is much more simple than asked before. What about the anticoagulation planning here for this case? Because this case is skipped on oral anticoagulation for the metallic valve. What is the strategy before starting your implantation of TAVI?
Actually, we kept the patient on. So if it's about interrupting warfarin, this was one of the risks which I should have mentioned. We went without interruption of warfarin, and ultrasound guidance. Femoral access ultrasound with ultrasound guidance. Of course, we can't go blindly. Make sure we target the right spot. Use Toproglide safely. Of course, it's at the risk of bleeding, but we were not in a luxurious position to say for the immunosuppression, you have to stop warfarin 2 days before. So we had to go with what we have got.
Sunel in Liverpool, if you face such a case, you will do what Amr did in the case, or you will have a different strategy?
Overall, I think we'd probably have the same strategy. The last few cases we've done with a metallic mitral, we have used balloon expandable because that is our preferred option, again, with high deployment. The PCI is interesting. We may not have done it normally, except that here, when you're going to deploy your SAPIEN high, then it probably makes more sense because you're more concerned about how difficult it will be to re-access the coronary. Shockwave definitely would have done the same. And I think the slow deployment is very important. So I think the last case we had of this, we did it under general anesthesia. And we also used a temporary pacing wire rather than pace through the left ventricular wire, because I think sometimes we use the pushing and pulling of the LV wire just to help the valve positioning. And I think if you are pacing through it, there is a risk of loss of capture. So, but yeah, I think it was a great case with lots of great planning. And I think that is the real key to all these cases, is all thinking, about every aspect of it before you go in.
If there is any burning questions from our elegant experts there in every field in the cardiology, intervention, structural imaging, I think what a wonderful night, what a wonderful cases, what a wonderful educative and learning points presented this night from the bunch of cases presented elegantly by my dear colleagues and experts, and also moderated and discussed by the experts in the fields. So I'd like to thank you all for this wonderful night, wonderful cases, and we hope to meet again. We hope to be here again in the case box for much more cases, for much more education. I'd like to thank my co-partner again, Dr. Hatem Sulaiman, because this case box is joined by the Harefield Hospital and nicely presented by 2 cases. And also I'd like to thank you all, Amr Gamal, Sunil from Liverpool, Ahmed Al-Sayed, Yasser Sadiq, Nirina Okasha, Ahmed Farid, Shadi Hussein, Ayman Abu Al-Mad, Professor Ayman, Professor Heba, and Muhammad Zaina. I'd like to thank you all and have a nice night and see you again very soon. Thank you very much.
Thank you. Thank you. Have a good day.
Bye-bye.
Thank you very much. Good night.
Thank you. Thank you. Good night.
Good night.